All right, good morning. I'm Natalia Hernandez-Hidden. I work with Dr. Reedy at the multi-specialty clinic on Old Jacksonville Road. It is a pulmonary clinic. Most of what I do is all sleep medicine at this point. So thanks for inviting me to come talk today. Thank you all for attending. And so my background was 8 years in emergency and trauma nursing. A certified emergency nurse. That's all I thought I ever wanted to do my whole life. I've worked at 5 different emergency departments in 4 different states. Kind of worked through the ER the whole time I was working towards getting my nurse practitioner degree. And then once I became a nurse practitioner, I figured I'd had enough of that. A little bit of burnout, a little bit of chaos in the ER, and went into neurosurgery, which is nothing like sleep medicine. So picture on the top is kind of what we market as. That's what you get. The one on the bottom, as we all know, that's usually what you actually get. I worked with adults and pediatrics with a specialty focus in pediatric surgical concerns, spina bifida, shunts, cancer, all kinds of really cool kind of stuff. Did inpatient coverage, surgical first assist, clinic coverage. It was really fun. My husband's job brought us to Springfield last summer, so I've been working now with HSHS since August in sleep medicine. Kind of coming from a very chaotic, kind of loving the chaos background of the ER, and then neurosurgery. Clinic life is very different than working in the hospital. Things are a little bit easier to manage, so I did the most logical thing to create chaos in my life and applied to SLU. I'm starting the doctoral program soon, which is I'm hopeful for an eventual tie-in with Prairie for some future projects, so I'm excited to meet you all for that reason too. So pulmonary and sleep medicine, what I do in sleep medicine is kind of a variety of things. I do see some pulmonary concerns, but it is mostly sleep, insomnia, narcolepsy, REM sleep behavior disorders, non-REM sleep behavior disorders, shift work, circadian rhythm, but by far what we almost always see is sleep apnea. There is obstructive, central, and complex, which is a combination of the two, and definitely the majority of what I see is obstructive sleep apnea. Some of these are treated with CPAP. Most of them are treated with CPAP, some with other therapies. Sometimes they self-refer. Most of the time they come from primary care. The stop bang assessment tool is one that I see. Some providers use this with a referral, others don't. They just kind of say patient snores or we have concerns, but the stop bang is a really good way to kind of quantify the need for a sleep assessment. Components of stop bang are listed up there. Do they snore? Are they tired, either tired upon waking or progressively tired throughout the day? Do they have observed apneas? Do they wake up gasping, choking, feeling like they're underwater at night? Pressure, so hypertension, elevated blood pressures. BMI, body mass index, 35 or greater, so moderate obesity and greater has a higher prevalence of obstructive sleep apnea for men and women. Age, like everything else, things just get better with age. 50 plus increases your risk of having obstructive sleep apnea. Neck circumference, 17 or greater in men, 16 or greater in women. And gender, men tend to have this a little bit more often than women do. About 25% of men have an element of obstructive sleep apnea. Women, it's closer to about 10% until menopause. After menopause, we catch up with the guys and the numbers reach about 1 in 4 also. Pardon me. So sometimes people get a referral because they have some of these symptoms. Other times it's when I get them from Prairie or through endocrinology, a lot of times it's more for optimization. Patient's not aware of any trouble. The spouse doesn't complain of snoring. They don't feel tired. We're just kind of doing it just to kind of optimize their overall health. And that briefly just kind of talks about the stop bang scoring criteria. Next step I do is take a detailed sleep history. So I do this for all my patients, whether I'm seeing them for insomnia, REM sleep problems, or any type of sleep apnea. And what it entails is, have they ever met with anyone from sleep medicine before? Do they have any old sleep studies? Have they ever used CPAP for any reason? I'll ask them about immediate family history, so mom, dad, siblings, any of their children. Do any of them have a diagnosis of obstructive sleep apnea or CPAP use? We inherit all those anatomic characteristics from our parents, so sometimes if mom, dad have a narrow airway, you might too. I ask them what time their bedtime is, so what time they actually physically get in the bed as well as what time they generally fall asleep. How often do they have nights that it takes them longer than 20 or 30 minutes to fall asleep in a week, whether that's the majority or the minority of the time? Their perception or quality of their sleep. Do they feel like they're sleeping deeply, sleeping well, or do they feel like it's interrupted, bad sleep? Do they snore? A lot of people will say no, and their spouse will pipe up with, yes, they do. So a lot of times having a spouse there is kind of helpful for assessment. I'll ask them if anyone has ever told them that they look like they have pauses in their breathing, or whether they look like maybe they weren't breathing at all. Waking up feeling panicked. Do they have a racing heart? Do they feel like they're having a panic attack, sweaty at night? What time they wake up? Do they have to use an alarm clock? Do they hit snooze 5 or 6 times because they're so tired in the morning? If their sleep is refreshing, are they progressively tired through the day? Do they need to nap? Not need a nap is on the slide. Are they sleepy when sedentary? Are they having consequences of daytime sleepiness that are really affecting their life? Falling asleep at work, falling asleep at stop signs, getting into car wrecks. Those would be really ominous, good motivators for pursuing treatment. We also include a past medical history and a past surgical history. There are certain components of someone's past medical history that are kind of like red flags for me, and as they're talking, I just kind of jot those down, and those would be prior strokes, any heart conditions, reflux, headaches, depression, diabetes, sorry. And then we get an Epworth sleepiness scale. So an Epworth sleepiness scale is a way for us to quantify subjective symptoms of daytime sleepiness. It's on a scale of 0 to 24. Anything greater than 9 would be considered excessive daytime sleepiness. Then I move on to a physical exam. Physical exam, pretty much the same as just kind of a very general physical exam with special attention paid to a couple different portions. I always look at their Mallampati score. So if I look into someone's mouth and I see a class 1 airway, which is on the far left, I see that they've got a little bit more room for error if they did have some airway collapse. If I look in and I see a class 4 where I'm seeing nothing but palate and tongue, their likelihood of having obstructive sleep apnea is not only higher, but if they are overweight and they ask me if they were to lose a substantial amount of weight, they probably will not kind of grow out of having sleep apnea just because of that airway type. So I do that. I do a neck circumference, again, remembering 17 or above in males, 16 or above in females, heart sounds, lung sounds, and I always look for edema. People who have post-stroke or who have had any kind of cardiac conditions, there's sometimes more incidence of a central apnea. So sometimes these people don't present the same way that someone who has obstructive sleep apnea. They sometimes don't have the snoring because with central apnea you've got the open airway. Next, I will kind of talk to them about the physiology of obstructive sleep apnea. When everybody goes to sleep, our muscles are designed to relax so that we can get a good quality sleep. In people who have obstructive sleep apnea, when the muscles in the back part of the throat relax, all that overlying musculature, all that overlying soft tissue of the neck can start to compress the airway, and sometimes it closes it entirely. When the airway is closed entirely, when they go to draw in a breath, it cannot get past the obstruction in the neck. So by not bringing in any new air into the lungs, their oxygen saturation starts to decrease. This causes an increased sympathetic nervous system response. This causes them to have to wake themselves up to breathe. Okay? So the brain will have to wake them up to breathe, so it wakes them up out of sleep, and then it often doesn't report a memory of having to wake them up though, so it's just enough to take that breath and they slip right back to sleep, and that cycle that's listed there just kind of repeats itself over and over and over all night long. So people who have this, they don't get deep asleep and stay asleep. They're waking themselves up constantly all night long, which then manifests as those daytime symptoms of feeling tired, non-restorative sleep. No matter how long they spend in bed, they always feel tired. Obstructive sleep apnea can worsen a lot of other medical problems. It doesn't cause these problems, but it can worsen blood sugar in diabetics. It can even cause impaired glucose resistance, even in those with no formal diagnosis of diabetes. It increases blood pressure, increases risk of heart attack and stroke, can worsen lower extremity edema, worsen GERD, depression, headaches. So we feel like it's important to treat. Patients, sometimes when I'm kind of having this conversation with them, they'll say, well, why can't I just wear like oxygen at night? And then I have to kind of talk to them about the actual obstruction, and I show them a picture, kind of like the one there where I say this is completely choking it off. You can blow oxygen around your face all day long, If you don't bring it down into your lungs, you're not going to oxygenate your body. Moving on to looking at a sleep study. So when you get a sleep study back, there is a ton of information in most sleep studies, depending on the sleep lab. We've got some sleep labs that I get sleep studies from, and they really don't have a whole lot of information in them at all. But the most important things in there, and also when you read a sleep study, the very beginning of it will usually talk about how they calculate the numbers for the study. But the things that I really kind of zone in on a sleep study are the following. I kind of omitted on there, but I look at the date, which seems like, of course, you're going to look at the date. Sometimes they're really, really old, or sometimes it's 2 months old and the patient is requesting a new sleep study, and then we've kind of got insurance issues to contend with. But if I have multiple sleep studies, I kind of look at them chronologically and kind of see how has this evolved over time. So I always look at the date. BMI, again, understanding that 35 or greater is going to increase their risk of having sleep apnea, as well as with that, if I'm looking at multiple sleep studies, I can track how their sleep apnea ebbs and flows depending on how their weight has either increased or decreased. The sleep study should show you the time in bed, so the physical amount of time they got in the bed, as well as the total sleep time. That's in the case of an in-lab sleep study. An in-lab sleep study will definitively tell how long they were sleeping while in that bed. Whereas a home study, you turn it on, it thinks you're asleep, you turn it off in the morning, you're awake the entire time. It's considered sleep time. So I look at total sleep time. A lot of times when I ask someone, how did you sleep during your sleep study? They'll say, I didn't sleep at all, I slept awful. I'll see, 400 minutes in the bed, 320 minutes sleeping. And I'll say, well, it's the perception of bad sleep, but you actually did sleep. I like to look at the sleep onset time, pardon me, understanding that really profoundly tired people, it does not take them very long to get to sleep. That being said, if someone has a delayed time to get to sleep, it doesn't mean that they aren't tired. It's a test environment. You're attached to all kinds of weird stuff. Sometimes it's hard to get to sleep, but that can be kind of helpful. I look at the REM sleep onset. That is not so helpful in sleep apnea, but sometimes when we order a sleep study, it gives you so much data, we end up going down roads we never thought we were going to go down once we start getting that information. REM sleep within 1 hour, and less than 1 hour, is considered abnormal. Okay, so sometimes that can be indicative of a REM sleep disorder. More importantly for this conversation, I look at the Apnea-Hypopnea Index, AHI, or the Respiratory Event Index, REI. In an in-lab study, it's going to be reported as an AHI. A home sleep study will call that an REI, but essentially they mean the same thing. They are a severity of obstructive events or central events. And then lastly, I look, was CPAP titration attempted? Sometimes they try it, sometimes they don't. So looking at an AHI, an apnea-hypopnea index, again, that just calculates how many times did they have an apnea or complete cessation of breathing, how many times did they have a hypopnea, so decreased chest expansion, poor breathing, shallow breathing with accompanying oxygen desaturation. How many events are they having per hour? That's what the apnea-hypopnea index tells us. 5 to 15 is considered mild, 15 to 30 is moderate, 30 and greater is severe. I think the highest AHI I've ever seen in clinic was 165. So 165 events where they stopped breathing in an hour. So it's really, sometimes like we really go over this with patients. It's a good motivator to get them to do something about it. So where am I at here? After looking at the AHI, again, I'll look to see if CPAP was attempted. Overnight oximetry is not sufficient to diagnose obstructive sleep apnea. I get a lot of referrals, and reason for referral is, a bad overnight ox. So because we all know that if a pulse ox ends up kind of off kilter on someone's finger, on an overnight ox, I'm not provided with a waveform. I have no idea whether we're getting a true representation of what the patient's oxygen is or not. So if I get an overnight ox, it might say desat to 65. Did they really desat to 65? Did we have a poor waveform? Is it kind of a junky test? I don't really know, but sometimes it's just one more thing that we can kind of use along with the patient's symptoms to kind of justify, doing a formal sleep study. At this point, I like to talk to the patients about sleep studies. I'll kind of talk to them about the physiology. I usually go back over their history. I go back over the symptoms that they have presented, kind of telling them, this is why maybe this is happening to you. This is why we need to proceed with doing this. Sometimes they are really unaware of what a sleep study entails, so that's why I kind of talk to them about that. So a sleep study, You can either do an in-lab or a home sleep study. Generally young, generally healthy people, no history of any heart conditions, no stroke conditions, they can usually do a home sleep study. I will also order a home sleep study if someone was like, I am absolutely never doing an in-lab study again, you can't make me. I will send them with a home because sometimes it just, it's that or nothing. An in-lab study is a lot more complicated. It has a lot more information than a home study. In-lab study, they will go to the sleep lab of their choice. They will get attached to cardiac monitoring. They put an effort belt both around their chest and their abdomen to assess for work of breathing, pulse oximetry, EEG monitoring. So we can look at their brain waves. We can tell definitively whether they are awake or asleep, and that's why we get a better numbers with that test, just because we can actually tell whether they are truly asleep for all that time. A home study is kind of a tapered down version of that. There's cardiac monitoring, there's an effort belt, chest and abdomen, and then there's pulse ox. That's pretty much a home study. The way that they calculate the apnea-hypopnea index, again, I kind of talked about with our other slide, is just the total amount of complete cessation of breathing and poor shallow breaths divided by the sleep time. So therein you can see why an in-lab study would get you a more accurate representation of the apnea-hypopnea index versus a home study. If someone, is in bed for 8 hours but really only sleeps 3 or 4, the denominator for that equation is going to be huge. These are only events that happen in sleep, so the more we can trim that denominator or sleep time down, the better. Patients who are, again, elderly patients, I tend to do in lab just because we've got some supervising them, seizures, strokes, heart problems. I try to talk them into going to the sleep lab to have theirs done. And the last line I have on there, that they might qualify for CPAP during their study. They have a certain set of criteria that they're looking for in the sleep lab to determine whether or not they're going to try CPAP on someone. Sometimes people have poor sleep efficiency. We have to watch them the whole night long to even kind of get their diagnostic part done. Other people, they are really, really symptomatic. They fall right asleep. They watch them for 20 minutes. They can diagnose them, and then the rest of the night we can spend trying to figure out the CPAP part. So I usually do kind of talk to them, hey, when you're having your sleep study, you may or may not have someone come in the middle of the night, knock on the door, and try to apply CPAP. And that's when I kind of talk to them about CPAP a little bit, because if they're going to have something put on their face in the middle of the night, I feel like it's good to talk about that before they do it. So with the CPAP titration, I let them know that CPAP stands for continuous positive airway pressure. This machine does not breathe for you. It does not generally add oxygen, although we have the capability to add oxygen. CPAP just works by taking that airway that's kind of closed, forcing it open with positive airway pressure. Once the obstruction in the throat is relieved, the patient can naturally draw in a breath, fill their lungs full of air. This takes care of the desaturation in oxygen, stress on the heart, and the worsening of all those comorbid medical conditions we talked about earlier. It also had this secondary benefit of kind of alleviating some of that daytime sleepiness, frequent waking, better quality of sleep, all that. When they do a CPAP titration, CPAP goes anywhere from 5 to 20. They always start with the lowest pressure possible and just kind of dial it up until we finally decrease that AHI under 5. That's always our goal, is an AHI less than 5. Sometimes they go all the way to 20 and our AHI is still elevated, patient's not tolerating it. 20 is quite a bit of pressure, so we will switch to BiPAP, or the bi level. The only difference between the CPAP and BiPAP, again, is the 2 levels on BiPAP. BiPAP has both an inspiratory and an expiratory pressure. The expiratory pressure decreases so that the patient can kind of breathe off. BiPAP has higher pressures also, so we can work them up considerably higher on BiPAP. Sometimes we get that sleep study and, again, they didn't try CPAP. When I order a test, I always let them know we will try to get everything done in one night. We'll keep our fingers crossed for one night, but sometimes we have to go back to the sleep lab twice, sometimes more than that, depending on whether we find ourselves in kind of a complicated or unforeseen issues with the diagnostic part. There is fixed CPAP where we can order a specific pressure. So after a CPAP titration study, you will see sometimes the reading physician will say, best result found at 12. Then we know that we're going to treat at 12. Other times they don't have the CPAP part. I come back and I tell them, okay, your sleep study indicates you've got moderate sleep apnea. Now what? If they are fairly young, healthy, again, I can order them auto CPAP. So what auto CPAP is, we can order auto CPAP to flex between 2 set pressures. So I can set it all the way open from 5 to 20, or I can kind of narrow it down a little bit. Usually if I have no idea with where we're going to start or where we're going to end up, I'll do 5 to 20. And just that way the machine will always, it does it just like in the titration lab. It'll start at 5. If they have an obstructive event that needs more, it just keeps working up. The machines are smart. It will be able to record how often the patient is at what pressure. So when they come back for subsequent visits, I can kind of analyze what pressures they're utilizing the most, and we can kind of trim it down to find them a more accurate pressure. Then that way we're not kind of accidentally giving them pressures that they don't need. Once we decide that we are going to either do a fixed pressure, I have a fixed pressure recommendation, or that I'm going to do auto pressure, I have to pair with something called a DME company, Durable Medical Equipment Company, for these people to get their stuff. HSHS St. John's, we have no ownership of any of these companies. So I tell people you are a free agent. You can choose whoever you'd like to go through for all of these things. Once we write the order, it takes them about 2 weeks to get their supplies, and that tends to surprise a lot of people, especially if they're really anxious to begin therapy, if they're really aware of a problem, or they are either post-stroke or post-heart attack and they're really, really anxious to do something so that that doesn't happen again. Unfortunately, it takes about 2 weeks. They ask me all the time, can you fast track this? Not really. In the really unfortunate case of Medicaid, it can take them up to 90 days to get their machine. So if I see someone who's desaturating in the 60s, they stop breathing 100 times an hour, I just have to say, hope you get it soon. I will make recommendations for them not to sleep on their back because of the positional element, have them sleep upright. If they have oxygen, they can wear it at night. Goals of CPAP therapy, again, the goal is to keep that apnea-hypopnea index less than 5 with treatment. We kind of talked about those secondary benefits, which is decreased worsening of comorbid problems. Also, their perception of sleep often gets better. They feel more rested, less sleepy driving, not getting in trouble at work for falling asleep, which is always a good thing. Once I have the, sorry, we kind of covered 2 slides on that last one, so we already talked about pairing with the DME company. Once I write the order for CPAP, actually sometimes as soon as I start talking about sleep apnea, people start asking me about CPAP masks, because when they think about CPAP, they think about that big mask. So CPAP mask. Now the ones in this, on the top right, that's kind of what comes to people's mind when they think about CPAP. These big, huge masks. And to be honest with you, I've never seen that one in the middle ever, that one that's covering that entire face. But those are the kind of things that people think about when you start talking about ordering CPAP. They don't want to sleep with all that stuff on their face. The American Academy of Sleep Medicine, there has been some recent literature published that shows that nasal CPAP has it's slightly more efficacious than full face. But for the most part, I have no preference on what kind of mask my patients use. Really, whatever they like that fits their face, that they're willing to use, is the right mask for them. Full face mask was the first mask developed. A lot of people love full face masks. A lot of people hate them. They now make modified full face masks, which the guy on the left is wearing. What it does is it sits below the nose, still covers nose and mouth. This is good for mouth breathers who are kind of claustrophobic, who have had a poor outcome on these other masks, but know that really they need a full face mask. Sometimes just showing people the way that masks have changed in the last several years is a good way to at least get them to try it again. So I'll let them handle those kind of masks and kind of see how much they've changed.
Does the tube sit at the top of his head?
It does, yeah. So they have 2, that brand Philips makes 2 masks like that have the portion that doesn't go over the bridge of the nose. The first one they made, the tubing still came off the front, but then I think they took everything good about that mask and made this mask, kind of continued to listen to people about, well, I want to sleep on my belly or whatever. Because again, there are lots of excuses for not wearing CPAP or wanting to do it, so they kind of listen to people, and that's just one way. There's a couple different masks. There's some nasal masks that have that too for belly sleepers. So, nasal masks. There are nasal masks like the one on the top right. That one covers the entire nose. There are some like the ones on the left that's called a nasal pillow mask, where you can kind of tell where it shows the nose a little bit larger. It doesn't go up the nose. It just kind of rests at the nostrils. And then the last one is the under the nose. That's almost like a cannula style mask on the bottom right. That mask, I can get people to do a sleep study just showing them that mask. Sometimes when they are absolutely resistant, I will show them that mask and they're like, really? That's like oxygen? I'm like, kinda. And it helps because a lot of times they don't necessarily stick with it, but it's just trying it again. So there are a lot of changes, and that mask and the one that I showed you in the previous slide that had the under the nose, that one just came out this year. So they're constantly trying to do things to help people adhere because we know that this is not something that everybody's dying to sleep with something on their face. When I see a CPAP titration study, our sleep lab is really good about doing it. Outside sleep labs, not so much, but they will usually put, best result achieved on whatever pressure, patient used, Fisher-Paykel, whatever mask, size, blah, blah. And then I know that they got a good result on that exact mask, that exact size. So I'll ask the patient, what did you think of the mask they used in your titration study? If they say, I thought it was okay, I will write it down on my card and I'll say, when you get your CPAP, start there. We know that it was fit by someone who knows what they're doing, that it was the right size, and we got a good result. If they say, I hated that mask, I will write that mask down and say, show this to them and say you don't want to use that one. Or tell them what you didn't like about it, and they'll kind of help work towards finding something that's a little bit better for you. In monitoring the treatment, so when I write an order for CPAP, I have to let them know about the insurance requirements for use. People are great about getting a CPAP machine and putting it right in their closet and never using it again. So the insurance companies they're very vested in finding out whether people are really using this or not. The machines are expensive, the parts can be expensive. So insurance companies define good CPAP use as using it at least 4 hours a night. They do not have to be consecutive hours. These can be pieced together as needed. 4 hours in a 24-hour period, 70% of days in a month. So 21 days, at least 4 hours. I usually tell people that's insurance's goal for you. My goal is every time you go to sleep, the entire sleep cycle, bedtime, naps, you name it. I want you to wear it if you're sleeping. They will come back after about 2 months to clinic. That gives them 2 weeks or so to get their machine, except if they're Medicaid, then we really have to see them much, much later. But I like to have about 6 weeks of data to look at when they come back. So when they come back, they bring the machine or the chip that's on the machine downloads a lot of information for us. So I can tell whether they're meeting the insurance requirements. I can talk to them about what percentage of nights they're using it greater than 4 hours. I can look at their average nightly sleep. It will, pardon me, it will let me know what their AHI is on therapy. Again, my goal under 5, if I start seeing that kind of creep up high, we can make some changes. It'll let me know what pressure they're set at. If they are a flex or auto pressure, I can find out what their most commonly utilized pressures are and make changes. So it does have a lot of really good information for me. It lets me know, I can kind of talk to them using that download to help them identify possible problems, and we can kind of troubleshoot that together. It's a good way to have some accountability. Some of the machines are even smart enough to tell an obstructive versus a central event, because it can tell whether there's resistance or not. If there is no resistance, the machine knows it's central. Now, a CPAP machine is not going to get someone with a central apnea to breathe. It can't force a breath, but it does keep track of those. Barriers to CPAP use. I've heard all of them. And I've heard some really, really inventive ones. One of the biggest ones is claustrophobia. People don't like something on their face, and you can't blame them. People have their whole life going to bed a certain way, and then we tell them, no, now you need to have this 6-foot leash, and you need to have all this stuff on your face. So it can be kind of tough to get used to. Intolerance to pressure. This is usually with pressures that are on the high end, but I've had people that are intolerant to even 5 of pressure, so those can be kind of a challenge. They'll say that the mask is uncomfortable, the headgear is uncomfortable, mask leak. They have the wrong size mask or they don't put it on right. I suggest putting mask on while they are reclined. When you're sitting up and you put your mask on, face kind of hangs this way. When you lay back, your face is hanging this way, so it changes the dynamic of how that mask fits. So there's a lot of little things that we kind of work through. Sometimes people tell me they feel unattractive to their bed partner, which, we have to validate those concerns. We have to kind of say, we understand, but they're going to be very happy if you are healthy and around. You have to kind of walk them through some of that stuff. And I put that picture on there because I've had so many women tell me it messes up my hair. I can't do it. I'm just kind of like, okay. Best excuse I've ever heard for not wearing CPAP for like a month, it was Super Bowl. It was Super Bowl, and I thought, there is no way with an elaboration on that excuse that it will make any more sense, so I did not explore. Motivating my patients to use CPAP. So if we're having some troubles, I will then kind of go over their sleep study with them again. I'll say, okay, let's talk about your sleep study that you had in, 2014, 2015, whenever. And I'll say, when you slept, you don't breathe 70 times an hour or whatever it is. I'll talk to them about how low their oxygen gets and how our goal is to keep their SpO2 90 or above. I'll kind of talk to them about their medical history, saying, hey, you're diabetic. This is a way you can control your blood sugar. You've had a stroke before. If you want to decrease the risk that you have another stroke, you've got to use your CPAP. The risk factors, I'll talk to them, you say you're sleepy. You said you fell asleep at a stop sign. These are things that you can do. So sometimes it really takes kind of going over and telling them things about them specifically that can be that motivating factor. I talk to them about how, CPAP is kind of like quitting smoking, eating healthy, exercise. Those things don't necessarily, like modifiable versus non-modifiable risk factors. It is not going to make your diabetes maybe go away, but it can kind of sway things in or out of your favor. So I really try to have that talk with them about this so that they have a good understanding. And I usually let them know too, my job is not to chastise you or to tell you that you're in trouble. My job is to give you all the information you need to make a good decision about what you want to do. I might not like it, but they have to make their own decision. Again, I keep a handful of different CPAP masks in my clinic. I'll show them full face masks. I have a couple of those little modified ones that go under the nose but over the mouth. I have some of the little ones. I'll let them handle them so that they can really have an idea of what that's like. And again, go over the download to troubleshoot problems. I can see whether they're having a lot of leak. I can see, sometimes they'll say, oh no, I'm wearing it all the time. Things are going great. And I pull the download and I'm like, you wore it 9 days in the last 50. So, and I'm like, we have to kind of talk through this. You have to be honest. We do have something called a sleep assessment that we can order at our sleep lab. It is not an overnight study. You basically go and work with someone at the sleep lab that is a polysomnography tech who's also a respiratory therapist. She's kind of our CPAP guru. She will have someone go in, bring all of their stuff, plug in their machine, watch them put their mask on, make sure that the mask is the right fit, and just kind of walk through some of the things. Does she suggest a different size mask? And then she always writes a report and sends it back to us. Sometimes she'll say, they hate their pressure of 14. Can we do auto 10 to 17? And I'm like, sure. Whatever gets them wearing it, I'm happy with. I usually will see someone a couple different times that's having compliance problems or CPAP problems before I start talking about alternatives to CPAP therapy. CPAP is the gold standard for obstructive sleep apnea. It is the relatively simplest intervention that gets us the very best results, but there are a couple other options. And if I see someone who is just absolutely failing, we will start to talk about those options. The first of which is oral appliances or mandibular advancement devices. It's kind of hard to tell in that picture, but on the far right, how it looks kind of like a little retainer, it is a 2-piece retainer. That yellow portion that looks gigantic in that picture, that is adjusted by a dentist. What they do is that helps push the mandible forward, kind of causing prognathism, and that's like a jaw thrust maneuver. And if you even kind of push your bottom jaw forward, you will feel how that kind of lifts those muscles up and off of your airway. This is really good for people who have mild to moderate obstructive sleep apnea. A lot of times having a goal of 5 or less on an AHI is not always achievable, especially if at baseline they're 50. We're probably not going to get them under 5 with using an oral advancement device. They will often have residual apnea. How this works is we refer to a dentist. Dr. Reedy and I use a dentist here in town that is double boarded. He's dentistry and sleep medicine. He's the only one south of Chicago in the state. We refer to him. He does molds of the patient's teeth. If they are edentulous, they can sometimes do something to hold it in place, even if they wear dentures. But it's about a 6-month process. It does take a long time. It's covered by medical insurance, not by dental insurance, because even good dental insurance doesn't pay a whole lot. So that's usually a concern is finances for people. But if they're absolutely intolerant to CPAP, this can be a good therapy. After the oral appliance is made, we send them back to the sleep lab so we can kind of compare baseline versus with an oral appliance in. Once we have the new apnea-hypopnea index on that oral appliance therapy, I'll kind of tell them, here's where you're at. Are you okay with your apnea-hypopnea index still being, say, 15 elevated, whatever it is? And then I will just kind of talk to them about, you still have residual sleep apnea. You have to be willing to take on the fact that you could still be having some risk from this. There are surgical interventions for sleep apnea. The uvulopalato-pharyngoplasty, which is much easier to say as UPPP. This is a way to remodel soft tissue in the back of the throat. It removes the uvula and portions of the soft palate. You'll see patients that look like on the far right when you go to do an oral exam. You can kind of tell very easily when someone has had this surgery or not. I have a lot of patients that are on CPAP that have had this surgery. They still have that airway because this surgery is marginally effective. Good for mild to moderate sleep apnea. It used to be kind of marketed as something that would be a lot more beneficial than what it truly is. So this is an uncomfortable surgery. Ask anyone who's had an adult tonsillectomy. It's very painful. Second surgical option, which has actually been shown to have quite a bit of promise in the last several years, is hypoglossal nerve stimulation, cranial nerve 12. How this works is it's much like a vagal nerve stimulator for someone who has seizures. There is an implantable battery pack that goes in the patient's chest. They can turn it on before night. What it does, and you can see in the picture, it has a little monitor that goes to the sensing lead down to the lungs. It can tell whether or not someone is breathing. If they are having trouble breathing, it sends some mild stimulation to kind of stimulate all these muscles to stay open. This surgery is effective at reducing AHI to therapeutic levels. It is, it's kind of hard to get approved in that we have to kind of go through some steps of failed CPAP and lots of documentation, but it is a promising surgery. It's a quick surgery, relatively low risk as far as surgeries are concerned. When I talk to people about this, I tell them this is not currently being done in Springfield. This is something you would need a referral to St. Louis or Chicago to have done. I kind of talk to them about the surgical process. I did work in neurosurgery. I'll kind of talk to them about this is easy. This is like an hour-and-a-half long surgery. And usually by the time I'm done talking to them about surgery and everything that goes, all the inherent risks of surgery, bleeding, pain, whatever, they're like, absolutely not. And so sometimes just talking about surgery is a good motivator for people to get back to using their CPAP. This talk was mostly about obstructive sleep apnea because I'm talking to you all in cards. I wanted to kind of talk to you about central sleep apneas, which are really common in cardiac patients. And those people who are on an adaptive servo ventilator for sleep apnea that have centrals. It is contraindicated to use an adaptive servo ventilator in someone with an EF less than 45. It increases morbidity significantly. When they did studies that found out that it increased it and had such a strong negative impact, they started kind of almost like doing a recall. This was several years ago. But we do just kind of have to keep in mind, if you ever have a patient you're doing an echo on that you know has central sleep apnea on an adaptive servo ventilator, and you catch a EF of 45 or under 45, 44 below, they need to discontinue that ASV immediately. Okay?
What's the correlation there? I mean, what's the mechanism of the increase?
You know, that part I'm not 100% sure
I remember reading about that, but I couldn't ever.
Yeah, I would have to refresh
what
myself
caused
on
it.
that
Okay.
because I have actually only had just a couple patients that I've had to take off their ASV.
Okay.
So I could look into it and let you know. I just don't recall.
We don't see it that
offhand.
often, but I
Okay.
just remember there was that big.
Did you just
Sure.
change them to CPAP? Because that's not really.
Sometimes that's not effective. Sometimes there is PAP-mediated worsening of obstructive events. Some people have sleep apnea that's more obstructive in nature, or maybe some centrals. You put a PAP on them and start increasing pressure, for some reason, it starts making them throw centrals sky high. So sometimes in these patients, we have to say, sorry, there's nothing. There's nothing we can do for you, only because PAP a lot of times will make it worse. Before they've had a servo ventilator, they've usually tried PAP. So we almost always have, we can kind of see this, again, the chronological sleep studies that you end up doing, you kind of trace what was going on. PAP didn't work, BiPAP didn't work, or it started making them throw so many centrals that we knew that we would need ASV. And then as they have some decline, when that EF falls below that 45, we just kind of have to stop. And that's when we talk to them about, you need to do things to decrease your risk of having worsening of sleep apnea. So avoidance of opiate medications if you can, avoidance of sedative medications. Anything that's relaxing or sedating just causes more muscle relaxation, just causes more problems with obstruction, having them sit upright, sometimes oxygen at night, and sometimes that's all we can do. That's the end. So, got some of the best questions right at the end there anyhow, but do you all have any questions for me about anything that we've talked about?
Can we send all of our sleep apnea patients to you?
Absolutely, that's what I want you to do. That's what I'm hoping for. Dr. Reedy had seen sleep for a long time. He still does continue to see some sleep. Patients who are insisted upon seeing him, he can have them. But for the most part, he's sending almost anything having to do with sleep to me so he can concentrate on some other stuff. So, and I'm getting a little bit busier, but yeah, I'm ready for him. Send him.
And we don't have to have a sleep study
You do
before we send them
You
to
don't.
you.
I kind of talked to Dr. Reedy about what his opinion was one time about whether or not someone should have a sleep study before or after, and he's like, well, he prefers to order the sleep study himself, just because we have more time. I mean, our entire visit is spent talking about sleep. So we can really, really talk about all this stuff at length with people so they have a little bit better understanding. But by all means, if you're comfortable ordering a sleep study, you feel comfortable talking to them about a sleep study and they're receptive to doing it, then just go ahead and order it. Because that's kind of nice too, because then once I talk to them about their symptoms and I start talking to them about the physiology of it, then I can say, we got a sleep study in hand. Let's make this make sense for you.
I've only ordered a few sleep studies, and I wouldn't say I'm comfortable with doing it. So what, terminology do we need to use to order a sleep study? Because there's lots of options in the computer, and
I always just order a split night sleep study. The one thing is I've had a couple people, because of documentation for necessity of sleep study, they've had their CPAP taken away and we had to order a whole new sleep study. Insurance rules are ridiculous. Just make sure that your note contains something, whether it says for cardiac optimization or snoring, daytime sleepiness, whatever, any one of those things is going to qualify them for that test. But if there's nothing in the note, I've had to message people and say, hey, your note doesn't say why you ordered this, just throw something in there. And sometimes even just asking them to just throw that one little thing in there can kind of take a while. But as long as you say something while you're ordering it, you're fine.
So then you said a split night
sleep study.
Okay.
I prefer ones from our sleep lab for a couple different reasons. Firstly, Dr. Reedy reads all of them. So the read time is really fast, like probably the fastest out of anywhere. Some of the outside hospitals, I will get a sleep study result back that, it's like this much information and that's it. And it's really not very helpful. They don't have a titration table. They'll give me a baseline apnea hypopnea index, but it'll say good resolution found at 10. Well, what's good resolution? What exact number did that bring it down to? So it kind of, it can make things kind of tough sometimes, because then when I get a download and I show that their apnea hypopnea index is still 12, I'm like, well, did they consider that good resolution? I don't really know what we're talking about. So I prefer our sleep lab, as opposed to especially some of the smaller community hospitals, Passivant, things like that. They kind of get kind of sketchy sleep studies, but Memorial's great. Springfield Clinic gives us good sleep studies too.
I'll have to know you're repeating them. Like, I have some patients that come in and I'm like, so how long have you had your CPAP? And they're like, 11 or 12 years. My primary gave it to me. Nobody checks up on it.
Right. Yeah, every now and then I'll get someone who their primary care will hear that they've been on CPAP for years and years, and it's like someone just gave it to them, just released them into the wild.
Right.
Most of the time, they are surprisingly doing okay when they come back and see me. Other times they'll say it was brand new, it's really old, it's been hanging out in the closet, it's covered in dust. Depending on whether they've had any big changes in their medical history or significant weight gain or just kind of something else that makes me feel just a little off, most of the time I can use an old sleep study, like really old sometimes from like 2000 or 1999 to qualify them again for CPAP. Sometimes we'll do another CPAP titration study only, just to kind of see, what's changed with pressure, but we kind of knew what was going on baseline. As long as, again, no big changes in medical history, that's probably pretty representative of where they're at now.
Do you also go to Litchfield Clinic?
I do not. Dr. Reedy goes one time. I think he goes the last Wednesday of the month. He will go to Litchfield. I have a lot of patients that come up from Litchfield, though.
Yeah.
Nope, I stay put.
For the majority of patients that are on Medicare, what is the cost to them for the sleep study and the CPAP machine?
That part I also don't know, just because people will want to ask me, or it's with all insurance. They'll say I have Medicare, but I also have secondary insurance, and I do or don't have the Part D. How much is this going to cost? And I usually I refer them straight to our front desk. I say let's just talk to someone with billing and finance it, because I don't know.
Do you have issues, like we have certain medications that people are really hesitant to take because of cost?
Mhm.
Do you ever have complaints about that?
No, not really.
So it must be
Because
pretty good
insurance,
coverage.
for the most part, insurance will cover someone with a qualifying comorbid problem. So if you have someone that's had that's got really significant coronary artery disease, post-stroke, AFib, congestive heart failure, diabetes, hypertension, if their AHI is over 5, insurance is going to qualify them. Insurance likes keeping money in their pocket. So if they see something that could potentially cost them more money, they will pay money to make it go away. So they will start these people on CPAP if they have a mild apnea-hypopnea index. Otherwise, if it was someone who had no comorbids, fairly young and healthy, they want it to be 15, even though American Academy of Sleep Medicine feels that we need to treat everyone that has sleep apnea. Insurance companies will only qualify someone with no comorbids if they're 15 or greater. But otherwise, no, we don't generally have problems with them arguing about wanting to initiate treatment. I've very, very rarely had to do like a peer-to-peer to justify doing any of this. Sometimes to justify doing an in-lab sleep study, like if I feel like really strongly that they need to be in the lab and have more monitoring, sometimes I've kind of had to argue about that a little bit, but not too often.
So the parts, how often does the mask need to be replaced?
It
or-
varies from what type of mask they use, but generally the part that makes contact with their face, 1 to 3 months. The housing that kind of snaps into that goes along with the headgear is every 6 months. Tubing is 4 months. It has little filters that need changed periodically. I do see a lot of patients that I will see them, they got set up in 2004 and they're using the same mask, the same tubing, and then they, upper respiratory illness and stuff like that. I'm like, well, the silicone's brittle and yellow and we need to change that. Yeah.
I had a patient who said he didn't want to wear CPAP because he was worried it would make him sick from the appliance.
Mm-hmm.
It would get fungus in it or something like that.
I tell people it has the potential to get yucky stuff in it. It kind of, you have to think about someone's home environment. Not everyone has the neatest, cleanest home. Not everyone is going to keep up with those filters. Keep it dark. I mean, it does have a humidifier. It's adding water. It usually sits in a dark place. If that's going to sit there for a while, it has the potential to maybe make someone ill. So we do kind of stress the importance of keeping it clean. They make some CPAP cleaners that are really heavily marketed now. People seem to like them if they're willing to pay for them. They're kind of spendy. But distilled white vinegar, little elbow grease, you will get it just as clean as it needs to be.
There was a question online. You said, at what level will weight change prompt you to redo a sleep study?
That's a good question. Okay, so for people who are overweight, a lot of them will tell me, they acknowledge that their weight has a component to their sleep apnea. Even if they have like a Mallampati 4 airway, I'll always encourage them to try to lose weight, and then we can always revisit it, because it may not make it go away, but it might reduce their symptoms to where maybe they don't have to do CPAP, and maybe they could do an oral appliance successfully. I usually tell them if you were to lose 20% of your body weight, we can revisit this. A lot of times then insurance will say, sure, that's fine. We can put on there, we're doing a sleep study, significant body weight, reduction in symptoms, concern that maybe we've alleviated symptoms, and then they'll usually qualify it.
How often do you see people not have to use CPAP at all anymore with weight loss?
I've seen it once.
Really?
I've seen
So
it
not
once.
very often.
No, but that's given the fact that I've been working doing this since October. too.
Right.
So I haven't had a lot of time, but I have only seen that just one time, that she got way down to normal. And I thought she was going to be upset because she was one of these people that told me, I cannot sleep without my CPAP machine. And I thought, shoot, this last sleep study is going to tell her she doesn't get one. And I told her, and I was waiting for her to be like, well, what now? And she was like, oh, thank God. And I thought, oh, that makes my life a lot easier, because I'd gotten myself all, psyched up in this before I went to go see her, like, okay, we're going to do this. We're going to tell her she can't have it. And then she didn't want it. So it turned out great.
It's great.
Yeah.
Does that evaluation, sleep study evaluation, help somebody get qualified for bariatric surgery?
I don't know that part. I have been meaning to get in touch with bariatrics here, because there have been a couple people who have asked me for bariatric referrals, which, I don't know which is, if they're going to really accept that for me or not. I usually kind of refer them back to primary care for that, but I usually do tell them this is something that can make it better. There is obesity hypoventilation syndrome, where just because of the excess weight and extra work of having to breathe a little bit harder, that sometimes they have compounded sleep apnea, and that they are more hypoxic. Sometimes they even have like a poor ABG during the daytime because of nighttime stuff. So,
Wow.
yeah.
Any other questions?
And so about the oral appliance, if we're seeing patients who they feel like they've already exhausted their CPAP years ago and now they were never considered for an oral appliance, would you prefer? And I feel like I might have resistance sending them back to sleep medicine because they'll feel like they've already done that. Can you share who you send them to, or you
I would
really
still,
prefer
I
to
would
see
still
them
refer
back?
them to us just
Okay.
because they're going to need that. They're going to need long-term follow-up. Even if they successfully started adhering to a oral appliance, we still see oral appliance patients once a year.
Okay.
And that's just to make sure that they are having their symptom control. We're the ones that will do the follow-up as far as ordering the sleep study afterwards and kind of talking to them about relating it all together. So I would still do a referral to sleep for that.
Do you have any idea the cost on the oral appliance? Because I've had patients telling me that it's not getting covered by their insurance, and they won't tell them how much it's going to cost. But maybe
The
he just
initial
doesn't want me to
cost-
pursue it further.
Yeah, and that might be because maybe they aren't having enough qualifying CPAP failure attempts. It's kind of hard telling. I think that the initial cost of an oral appliance is more than the initial cost of CPAP. Long-term cost is cheaper only because you don't have, constant little parts that you're getting over years and years. Yeah. Sometimes the oral appliance will need adjusted, kind of that little yellow part on there. Sometimes they will have to make adjustments just to kind of push the jaw forward or back. But for the most part, once it's made, as long as dentition stays pretty much the same, it's kind of ready to go for a long time.
Anything else? Okay, we have to do our quiz.
I'm gonna let you
So if everybody will pull up a browser, it can be Safari or Internet Explorer on your phone, and type in Kahoot, KAHOOT.it. This is how you get your CME, so everybody has to participate.
We don't have we didn't bring my phone.
You can just answer in your head, I guess. Or somebody can play on my phone. Okay, so let me get the game started. And once we start the game, there will be a pin that you put in.
So what's the browser again?
Kahoot, KAHOOT.it. And this is the number that you put in right here. And you can put your name or. No naughty nicknames. Can everybody get on that has a phone?
Yeah, no.
Jen, did you get it?
And I think it comes up on the screen.
Got it?
Yep.
Everybody else good?
I have the same thing as someone else I was trying to do teacher.
Okay. So, what type of sleep study would be indicated or covered by insurance for a 25-year-old male with an 18-inch neck circumference and a history of diabetes? So you select whatever color correlates with this, with the answer you want to pick. And there's a timer, so. I'm going to start reading the next one because the timer is kind of quick. So, a 65-year-old patient's sleep study reveals an AHI of 10.2 and they have heart failure. Are they eligible for CPAP? So, a 65-year-old person with an AHI of 10.2 and heart failure, are they eligible for CPAP? Okay, so the correct answer was yes, the AHI is greater than 5 with a qualifying comorbidity. So there's a 59-year-old male with CHF using an ASV for central sleep apnea. Is he a good candidate for the servo-ventilator use?
Ejection fraction of 35.
That's the key.
Yes.
Great. So, like she said before, it's contraindicated with an ejection fraction less than 45. Okay.
Go, Sean.
So the next one, your 48-year-old male patient has a history of obstructive sleep apnea with CPAP non-compliance. Will overnight oxygen administration help with SpO2 or treatment of obstructive sleep apnea? I should have made the time longer. I'm sorry, guys. So it's minimally effective at increasing the SpO2, and the AHI will remain unaffected because it doesn't help with the obstruction. Okay, last one. I'll go ahead and start reading this one. That way you guys have more time. Your 62-year-old female patient has a history of obstructive sleep apnea with CPAP noncompliance. She is not receptive to another attempt at CPAP, and her AHI is 56. What is a reasonable alternative for CPAP therapy for this patient? Okay. So, do you want to explain this one?
Sure. So her, the severity of her apnea hypopnea index at baseline of 56. If we do an oral appliance, if we're lucky, we'll get it down to 35-ish, which would still be severe. Yeah. So that's better for mild to moderate. Yeah. Severe sleep apnea, we can get a really good result with that surgery if they're willing to do it. If someone like that is unwilling to do CPAP, then we can do an oral appliance.
And what is this?
A Zipa, if you guys have not heard the commercial for a Zipa, I have people ask me about them all the time. It's Happy Z spelled backwards. It is
Clever.
It is, you'll see any way people will try to not use CPAP, and they have all these little funky things you can buy online, and a Zipa is one of them. They even have this little funny thing that you squeeze and you put your tongue into it, and it sucks your tongue into it, and you sleep with this crazy thing with your tongue suck. It's just, yeah, people really will try anything to not use CPAP. Yeah. But a Zipa is one of those really, really annoying commercials. It seems like people always ask me about the Zipa.
I've seen the thing. It's like a pillow stimulator. Like it'll, like a little egg. You sit by your bed,
Uh-huh.
and then, that may just be for snoring though. And then if you start snoring, then
Does
it
it
like
raise
shifts. Yes, it
Yeah.
shifts your pillow to move your
Mhm.
head.
Yeah.
You're just like-
a Facebook ad.
Oh, sure.
Now everybody's going to be having ads for like CPAPs because it listens to us. So.
Now, going back to the first question, I think a lot of people had that first question wrong. That was the young guy with diabetes, with the increased neck circumference. Which test for him? Diabetes in itself wouldn't be something that would need to go in lab. You could do a home study for him because he's young, no neuro problems, no cards problems. But
Okay.
sometimes someone will say, well, I really would rather do an in-lab. And I'll say, well, yeah, I will try, and I order it, and insurance says no, and I call them, and we order a home, yeah. And sometimes someone will have a very clear indication for an in-lab study, and I will still have an insurance company try to deny it. It's just what they do.
We're more likely to do the home study. It must be quite a bit less time.
Yeah.
Is it a lot quicker to get the home study done?
It is a lot quicker to get the home study because as long as they have the availability of the home monitoring equipment, like ours has a handful of them, and it's just a little device. They go to the sleep lab, they explain to them about how to put it on, and then they take it home and return it the next day, and then just everything gets downloaded. So that can happen pretty quickly. I'm sure you guys have seen if you have ordered a sleep study. I know when I'm talking to a patient, especially if they're anxious to get it done, well, they'll say, well, can I do it this week? And I'm like, no, you probably can't do it this month. I mean, we're probably looking at 4 to 5 weeks out most of the time. If someone is a retiree or has a lot of wiggle room with their schedule, sometimes I'll say, we can put you for a first available. They also have a cancellation list because inevitably people will cancel their appointments, and then they try to keep the sleep lab as full as possible. So if they have enough notice, they'll start calling those people on that cancellation list, and if they don't have a very busy schedule and they can get in there, we can get it done a little faster.
Any other questions? Okay, thanks guys.
Thanks.
Cool.
Thank you.
Thank you all for listening. Yeah.
I have many questions from patients about sleep aids in terms of pharmacologic care, which I just discourage them to,
I
they
am
tell you
not
to see somebody that these are
Oh,
not
I'm
usually.
sorry.
It's okay, I paused too long and it.
treatment. So if you had like an uncomplicated person in terms of, but yet maybe they've been given a sleep aid, do you think that's somebody that should be an in-house, or what do you think?
No, I'm not a proponent of sleep aids.
I just told them
I
they
think
don't work
they do a
well.
lot more harm than good for the most part.
Yeah.
Most of them are not indicated for long-term use, but yeah, no
Thanks,
problem,
Amy.
thank you. But you'll see people who have been on these for years. Like my mother-in-law has been on Ambien for as long as I can remember, since I've been dating my husband, and she has all the weird nighttime behaviors, night eating, all that. There's a lot of bad stuff that goes along with that. And I see that more with my insomnia patients, which are the most difficult and challenging patients maybe I've ever treated is insomnia, just because it's just
Those
such
are
a
probably
problem.
people. I bet you have a lot. I have several, patients with insomnia.
People
complaining.
ask me for a sleep aid for their sleep study, and I will usually tell them no, because I want something that's representative of their every night. Now, if they're already on something like Ambien, Lunesta, whatever, and they say, I take this at night, should I take it? I'm like, oh yeah, because otherwise they are not going to sleep, especially someone who's on long-term chronic sleep aid. If we put them in a position where it's already uncomfortable, they're not in their house, and then we take away something that lets them sleep, they're definitely not going to sleep.
So you wouldn't do a home study on those, like?
Yeah, I would do a home,
thinking
if they take it normally at home, yeah, I could do a home study on that, yeah, no problem.
Because they're gonna
to
have
me, insomnia
sleep
could be
apnea.
so many things.
It
so I didn't
is.
know
And
if
it's the
they
same
are
thing
usually.
with fatigue, because I get so many of my referrals for fatigue. I'm tired, and so I will go through all the
It's like
sleep
my
stuff with
whole
them, and I
office.
tell them, now listen, we can do a sleep study, and if it comes back normal, then you can say, you know what, we've checked off sleep,
Yeah.
but the origin of fatigue is all over the place, and then that's when I kind of talk to them about, cardiology, pulm disorders, endocrine, all that stuff. I'm like, it could be anything. But sometimes I will order sleep aids for someone who is insistent that they are not complying and they just need something for just a couple days just to kind of acclimate. I'll order them like maybe a week, and then I will not renew that order. Yeah, because people come to me a lot looking for long-term sleep aids, and I'm not the girl. I'm
Yeah.
not the
Yeah.
right one.
Well, I don't encourage it either, but I'm thinking that if they're on a sleep aid and they've never had a sleep study, they should at least have sleep study, right? Or do you not
No,
always do that?
not really.
I don't
I mean,
really know where you start.
I'm just so leery of long-term sleep aids because I feel like, there's an origin to why you can't sleep.
Yeah.
Even if it's behavioral. A lot of times
But
people
it's appropriate to
sleep
still
schedule.
send them to you for insomnia.
Yes.
You will
Yeah.
help sort out if they
Yep.
need to go to behavioral
Yep.
or whatever.
Insomnia tends to make the most unhappy patients just because they're desperate. They want to sleep. They
Yeah.
don't understand why they can't sleep. And when you start offering like real interventions that have been shown to work, cognitive behavioral therapy, and they just glaze over, like it's very tough to get them to explore non-pharmacological, and it's also very difficult to get them to change behaviors because insomnia is the result of poor sleep hygiene, usually for years and years and years and years and years. And I find that in the retiree crowd, it's even worse. Because when you can do whatever you want, that's what you do. You go to bed a little later, you wake up a little bit later, you nap when you want. And it really just, over the course of years, it throws these people's sleep schedule off sometimes to where I have people that they're up and down every 2 hours, 24 hours a day.
Do you tell
It's
them
just-
that they should try to have a very consistent sleep schedule then?
Yes. Yeah, I talk
Those
a lot
some
about
people come in
sleep
and tell us it's the
hygiene.
diuretic we're giving them. That they took at 7 a.m. the day before. Like,
Right. Yeah, this just keeps me
it
up
should
all
still
night.
really be your
That's
diuretic.
right.